Hello everyone. Today we will cover topics like gastrointestinal stromal tumor, gastric lymphomas, duodenal tumor, duodenal obstruction, morbid obesity, gastric volvulus, and gastric dilatation. So the first topic is gastrointestinal stromal tumor. Gastrointestinal stromal tumor, in short, is known as GIST and is commonly found in the stomach and the duodenum. So previously it was leiomyoma or leiomyosarcoma. The term GIST is now in use, recognizing their particular distinct phenotype. So they are the rare tumors of the gastrointestinal tract, accounts for 0.2%. It's equal in both sexes and it's common between the age group of 50 to 70 years. Small stromal tumors of the stomach are probably quite common and they remain unnoticed for longer time. So it arises from interstitial cells of Kajal, which are the pacemaker cells of the stomach. So universally, they are associated with a mutation in the tyrosine kinase c-KIT oncogene and platelet-derived growth factor alpha. So these two genes are responsible for gastrointestinal stromal tumor. So based on the tumor size and the mitotic activity, GIST is classified as very low risk, intermediate risk, and high risk. So when the tumor size is 2 centimeter or less, we termed it as a very low risk variety. When the tumor size is 2 to 5 centimeter, it is termed as low risk. When the tumor size is 5 to 10 centimeter, it is termed as intermediate risk. And when it is more than 10 centimeter, it is high risk. The biological behavior of these tumors are unpredictable, but the size of the tumor and their mitotic index are the best predictor of metastasis. Peritoneal and liver metastases are most common, and the lymphatic spread is extremely rare so far as this is concerned. The only way to recognize stromal tumors are the mucosa overlying the tumor ulcerates, and later on it can bleed, or they are noticed incidentally while doing endoscopy. Because the mucosa overlying the tumor is normal initially, endoscopic biopsy can be uninformative unless the tumor has ulcerated. So to begin with, the mucosa over the tumor is normal, and as the size grows, afterwards the tumor ulcerates. So initial picture will be normal, but gradually as the tumor increases in size, so there may be ulceration. Larger tumors present with non-specific gastric symptoms, and in many instances it may initially be thought that they are gastric cancers. As the biological behavior is difficult to predict, the best guide is to consider the size of the tumor. If easily resectable, surgery is the primary mode of treatment. So, smaller tumor, if we encounter, can be treated by wedge excision, although the appropriate management of asymptomatic tumors found incidentally at endoscopy is unclear. Large tumor may require a gastrectomy or duodenectomy, but lymphadenectomy is not required as lymphatic spread is extremely rare. So these tumors are sensitive to the tyrosine kinase antagonist imatinib. Large tumors requiring multivisceral resection may be better treated first with imatinib for 3 to 6 months, as this will usually reduce their size and vascularity. So once the size gets reduced, it is followed by surgery. The prognosis of advanced metastatic GIST has been dramatically improved with imatinib chemotherapy, but resection of metastasis, especially from the liver, still has an important role. This is something about gastrointestinal stromal tumor. So next small topic is gastric lymphoma. So gastric lymphoma, it's always better to distinguish a primary gastric lymphoma with the secondary. So primary gastric lymphoma, they originates from the stomach. On the other hand, involvement of the stomach in a generalized lymphomatous process is known as secondary gastric lymphoma. So the secondary gastric lymphoma is more common as compared to primary gastric lymphomas. So incidence of lymphoma seems to be increasing. Primary gastric lymphoma accounts for approximately 5% of all the gastric neoplasm. Gastric lymphoma is most prevalent in the 6th decade of life. The presentation is no different from the gastric cancer, and the common symptoms include pain, abdomen, weight loss, and bleeding. Acute presentations such as hematemesis, perforation, or obstruction is not common. Approximately 90% of the patients of primary gastric lymphoma are either mucosa associated lymphoid tissue gastric lymphoma, that is mild gastric lymphoma, or diffuse large B-cell lymphoma of the stomach. Primary gastric lymphoma remains in the stomach for a prolonged period before involving the lymph nodes. At an early stage, the disease takes the form of a diffuse mucosal thickening, which later on may ulcerate. Diagnosis is made as a result of endoscopic biopsy and seldom on the basis of endoscopic features alone, which are not specific. Following diagnosis, adequate staging is necessary, primarily to establish whether the lesion is a primary gastric lymphoma or a part of a more generalized process. CT scan of the chest and abdomen, bone marrow aspirate, as well as full blood count are required to establish the diagnosis. No benefits has been shown from adjuvant chemotherapy, although some oncologists contend that primary gastric lymphoma can be treated by chemotherapy alone with CHOP regime. So it includes cyclophosphamide, doxorubicin, vincristine, and prednisolone. Other regimes we have MOP regime and ABVD regime. So MOP contains mechlorothiamine hydrochloride, vincristine, procarbamazine hydrochloride, and prednisolone. Regarding ABVD, it comprises doxorubicin hydrochloride, bleomycin, vinblastine, and dacarbamazine. It has also been shown that early gastric lymphoma may regress and disappear when Helicobacter infection is treated. Chemotherapy alone is appropriate for the patient with systemic disease. Gastric involvement with diffuse lymphoma. So these patients are treated with chemotherapy, sometimes with dramatic and rapid response. Surgeons are frequently asked to deal with this type of complication where stomach is involved. The two common complications can arise, which are bleeding and perforation. Both may occur at presentation, but more usually they may follow chemotherapy when there is a rapid regression and necrosis of the tumor. So these operations can be technically very challenging and normally requires gastrectomy. So next topic we have the duodenal tumors. So it can be benign and malignant. So benign duodenal tumors, so we have duodenal villus adenomas. So they occur primarily in the periampullary region. Although generally uncommon, they are often found in patients with familial adenomatous polyposis. The appearance are similar to those of adenomas arising in the colon, and as they have malignant potential, they should be locally excised with histologically clear margin. The malignant one is duodenal adenocarcinoma. Although uncommon, duodenum is the most common site for adenocarcinoma arising in the small bowel. Most tumor originates in the periampullary region and commonly arises in a pre-existing venous adenoma. So patient here presents with either anemia because of ulceration of the tumor or gastric outlet obstruction as the polypoid neoplasm begins to obstruct the duodenum, or as obstructive jaundice in direct involvement to the ampulla. Histologically, the lesion is a typical adenocarcinoma, and the metastases are commonly to regional lymph nodes and the liver. At presentation, about 70% of the patient have resectable disease, and for those who survives operation, the 5-year survival rate is about 20%. Poor prognostic features in the resected specimen include regional lymph node metastasis, transmural involvement, and perineural invasion. So these three features indicate poor prognosis. Curative surgical treatment will normally involve a Whipple's procedure, which is also known as pancreatico-duodenectomy. Other duodenal malignancies include GIST and neuroendocrine tumors. So neuroendocrine tumors will be that later on. Next topic is duodenal obstruction. Duodenal obstruction in the adult is usually due to malignancy, and cancer of the pancreas is the most common site or cause. About 1/5 of patients with pancreatic cancer treated with endoscopic stenting will develop obstruction. A variety of other malignancies can cause duodenal obstruction, including metastasis from colorectal cancer and gastric cancer. Primary duodenal cancer is much less common as a cause of obstruction than from other malignancies. Treatment is usually by gastroenterostomy, but duodenal stenting is increasingly being used. In patient having a surgical biliary bypass for pancreatic cancer, gastric drainage may be necessary. So other cause is annular pancreas, and annular pancreas may rarely cause duodenal obstruction. Obstruction usually follows an attack of pancreatitis, and on occasion the obstruction may be mistaken for malignancy. So this is the annular pancreas. So here the pancreas surrounds the duodenum. So this is the annular pancreas, and thereby there will be duodenal obstruction. Next cause is arteriomesenteric compression. So arteriomesenteric compression is a condition where the fourth part of the duodenum is compressed between the superior mesenteric artery and the vertebral column. So when it is demonstrated and when it causes weight loss, duodenojejunectomy may be performed. So this is the picture showing the condition. So this is the fourth part of the duodenum. This is the superior mesenteric artery, and behind is the vertebral column. So here we can appreciate the vertebral column, and this is the superior mesenteric artery. So the compression can lead to duodenal obstruction. So when it is demonstrated or when causing weight loss, duodenojejunectomy should be performed. So this is the operation, duodenojejunectomy. So anastomosis between the duodenum and the jejunum is to be done in such situation. The next topic is morbid obesity and surgeries. So morbid obesity is defined as being 100% over the ideal weight in relation to height, sex, and age, or having a body mass index, that is weight in kg by height in meter square, of greater than 45. So it is an increasing and major health problem worldwide nowadays. A number of surgical treatments have been devised for morbid obesity, but none is free from problems. Selection of patient for operation should ideally be made by a team. So always a teamwork is essential. So besides surgeon, It should include nutritionist, endocrinologist, and psychiatrist to exclude major metabolic problem and severe psychiatric disorder before operation. The patient will often have a morbidity associated with severe obesity, such as hypertension, diabetes, or osteoarthritis. Preoperative counseling should include discussion of the possibility of perioperative mortality. Patients are at risk of postoperative respiratory problems and pulmonary thromboembolism. So the preoperative counseling is very important. So thromboembolic prophylaxis are essential, as well as the antibiotics are also essential to combat infection. Increasingly, surgery is performed laparoscopically. The two most common procedures performed are laparoscopic band procedure and gastric bypass. So these are the two commonly performed procedure for morbid obesity. So in lap band procedure, an inflatable cuff is placed laparoscopically just below the esophagogastric junction. Perioperative mortality is less than 1%. Band slippage may cause problems, and the long-term result seems inferior to conventional surgery. So we have this classification so far as operations are concerned. So they are classified as restrictive operation, largely restrictive, mildly malabsorptive, largely malabsorptive, and mildly restrictive. So by restrictive we mean we restrict the intake of food by creating a smaller pouch, and malabsorptive is that we create malabsorption syndrome. So the restrictive procedure includes vertical banded gastroplasty, laparoscopic adjustable gastric banding, laparoscopic sleeve gastrectomy. So here we create a smaller pouch in the stomach, so thereby we restrict the intake of food. So next group is largely restrictive and mildly malabsorptive. So it is done by Roux-en-Y gastric bypass. Largely malabsorptive and mildly restrictive. So we have procedures like biliopancreatic diversion and duodenal switch. So the restrictive procedure are solely restrictive, where a gastric pouch of volume 15 to 30 ml is created with a degree of outlet obstruction leading to delayed gastric emptying. The goal is to reduce oral intake by limiting gastric volume, produce early satiety, and leaves the alimentary tract in continuity, minimizing the risk of metabolic complications. So this is the first procedure, which is known as the vertical banded gastroplasty. So here two types of staplers are used. One is the circular stapler, which is being used here. So through and through we can see there is a stapling, circular stapling, and here we have the linear stapler applied. So this is the one boundary, restricted boundary, and this is the another restricted boundary, and here a band is applied. So this procedure is known as vertical banded gastroplasty. So here we can see the stomach size is this much only. So this is the restrictive procedure, and rest the gastrointestinal tract is normal, so there won't be any malabsorption. This is another technique which is most popular. So here a gastric band is applied below the gastroesophageal junction. So this is the small gastric pouch which is been created, and this is the band applied. So which is the adjustable type of band. As and when required, you can tie it or you can lose it. And so the complication is the slippage of the gastric band sometimes. So next surgery is laparoscopic sleeve gastrectomy. So here the majority of the stomach, right from the fundus to the pylorus, here like this, is removed, and ultimately the stomach is converted into a tube like structure. So thereby the volume of the stomach gets reduced. So this is known as sleeve gastrectomy. So next procedure is largely malabsorptive and mildly restrictive. So it includes bilio-pancreatic diversion. So we do this diversion of the biliary and the pancreatic tract. So here we can see the excision of the distal stomach. So this is the gastric pouch has been created, and Roux-en-Y limb is created. So the limb here is attached to the distal or terminal ileum. So this creates malabsorption. So this is the bilio-pancreatic diversion. So bile and the food comes in contact in this region only instead of higher up. So next we have the duodenal switch. So here it's just like the gastric sleeve gastrectomy. So this part is removed and the stomach is converted into a tubular structure, and then the transaction is done here in the duodenal part, and simultaneously the anastomosis is done. This is the jejunal anastomosis, and here it is the ileal anastomosis. So this is duodenal switch. So next procedure is largely restrictive, mildly malabsorptive. So this is Roux-en-Y gastric bypass. So by adding malabsorption, food is delayed in mixing with bile and pancreatic juice that aids in absorption of nutrients. So this leads to an early sense of fullness combined with a sense of satisfaction that reduces the desire to eat. So this is that procedure. So small pouch, gastric pouch is created, and Roux-en-Y limb. This is the Roux-en-Y limb. So the distal limb is anastomosed with the pouch, and the proximal limb is anastomosed with the jejunum. So the operation that has the best long-term result is gastric bypass. This operation can be performed laparoscopically, and although technically difficult, it is becoming a standard procedure for severely obese persons. So using a combination of circular and linear staplers, a gastric pouch is created. The pouch has no connection to the rest of the stomach, but is drained by a 70 centimeter through loop, and this operative mortality is about 2%. After these procedures, the patient must be managed in a high dependency care unit or ICU until the possibility of apnea and other complications are diminished. Epidural anesthesia is useful as it decreases opioid requirements. The patient may be introduced to fluids and some food on the first postoperative day. Dietary advice is important. The patient must understand that liquidized food or high calorie supplement are to be avoided. Patients should lose between 1/3 and 1/2 of their body weight over 2 years. So vomiting is common with this procedure, and vitamin supplementation is always advisable. Other condition, we have the acute gastric dilatation. So acute gastric dilatation usually occurs in association with the bilirubineal disorders or after surgery without nasogastric suction. The stomach, which may also be tonic, dilates enormously. Often the patient is dehydrated and has electrolyte disturbances. Failure to treat this condition can result in a sudden massive vomiting with or without aspiration into the lungs. So the treatment is nasogastric suction with a large bore tube, fluid replacement, and treatment of the underlying cause. Next small topic is trichobezoar and phytobezoars. So trichobezoars are hairballs and are unusual and almost exclusively found in female psychiatric patients who are often young. They are caused by the pathological ingestion of hair which remain undigested in the stomach. So in the stomach they get accumulated and ultimately turn into a hairball. So these hairball can lead to ulceration and gastrointestinal bleeding, perforation, or obstruction. The diagnosis is made easily at endoscopy or indeed from a plain X-ray. Treatment consists of removal of the trichobezoars, which may require open surgical treatment. Regarding phytobezoars, they are made of vegetable matter and are found principally in patients who have gastric stasis. So often this follows gastric surgery. So in phytobezoars, the vegetable matters get accumulated in the stomach and thereby it causes obstructive features. So this is the hairball. So this whole structure is consisting of hair and it resembles the shape of stomach, and this is the duodenal part. So this is hairball. Next, we have foreign bodies in the stomach. A variety of ingested foreign bodies reach the stomach, and very often this can be seen on plain X-ray. So if possible, they should be removed endoscopically, but if not, most can be left to pass. Even objects such as needles, which seldom cause harm, in general, an object that leaves the stomach will pass spontaneously. In contrast, attempted removal at laparotomy can be very difficult, as the object may be much more difficult to find than might be expected. So most adults who swallow foreign bodies have ill-defined psychiatric problems and may appear to relish the attention associated with serial laparotomies. So treatment should therefore be reserved for patients with symptoms in whom the foreign body is failing to progress. Next topic is volvulus of the stomach. So the rotation of the stomach leads to creation of gastric volvulus, which usually occurs around the axis and between its two fixed points, that is the cardia and the pylorus. So in theory, rotation can take place in horizontal axis and in vertical axis. So when the rotation occurs horizontally, this is also known as organoaxial rotation, and when it occurs vertically, it is known as mesenteroaxial rotation. So the horizontal or the organoaxial rotation is more common. This condition is usually associated with a large diaphragmatic defect around the esophagus, that is paraesophageal herniation. So always it is associated with some large diaphragmatic defect. So this is the horizontal rotation or organoaxial rotation. So this is the horizontal axis. So here we can see this rotation in this area, that is the involvement is say from the fundus to the pyloric antrum. So this is the vertical. So here is the vertical rotation. So it is, see the greater, this is the greater momentum, greater curvature, and this is the lesser curvature. So rotation is in this direction. The transverse colon moves upward to lie under the left diaphragm, thus making the stomach to go along with it. And the stomach and the colon may both enter the chest through this eventration of the diaphragm. So first, what we have to do is we have to diagnose this condition. So diagnosis is sometimes extremely difficult. So the condition is commonly chronic, and in this chronic state, the patient presents with difficulty in eating. Acute presentation with ischemia may occur. So it can be extremely difficult to sort out the anatomy endoscopically, and this is one situation in which contrast radiography is superior. So once diagnosis is established, we go for the treatment. If the problem is causing symptoms, then surgical treatment is the only satisfactory approach. So traditionally, open surgery has been employed, but this problem can be tackled laparoscopically also nowadays if appropriate skills are available. So what is done here is, first of all, the hernia is present. That hernial cavity is emptied. So the content, which is usually the stomach or the transverse colon, is reduced. As we here we can see the reduction of the content is been shown, and a defect in the diaphragm should be closed if necessary with a mesh. So the defect which has been created is closed first, and it is to be reinforced with the mesh placement. So defect in the diaphragm, as here is shown, is closed and it is reinforced with mesh fixation. It is advisable to separate the stomach from the transverse colon and then perform an anterior gastroplasty to fix the stomach to the anterior abdominal wall. So the stomach is fixed to the anterior abdominal wall. So this is known as anterior gastroplasty. So these prevent volvulus, and the hernia part, if present, is closed simultaneously. So this is the treatment which is usually given for this condition. Thank you.